You.
Thank you very much, Dr. Guy, Dr. Blumenthal. It's an honor to be here. Thanks for having us back. So we're going to just kind of have a bit of a soup to nuts anchor talk today, and then show you some challenging cases we have where we're able to use some of these skills and principles. So again, we'll sort of start off easily with looking at anatomy and screw placement, and then Dr. Terry Ishmael will talk about some navigation, more modern techniques. Um, and then finally, Steve will close it out with salvage techniques. Well, that doesn't work. What do you do? So we'll get started here. We'll have a good day. All right. Getting there, hopefully. All right, you guys see my screen?
Yep.
Excellent. All right, great. So again, we're just going to give kind of a soup to nuts talk today on anchor placement. So just an outline for us, again, just in the beginning, advantages, disadvantages of pedicle screws, looking at the spine anatomy, lumbar spine anatomy, and then some general freehand insertion techniques. So for the most part, again, at least on kids, we're doing mostly freehand technique here. There's certainly a myriad of other avenues to place your anchors. You can use K-wires for cannulated screws, fluoroscopic assistance, laminotomies, and then stealth image guided fluoro navigation or robotics. And then after that, you have to confirm where they are. So again, a number of ways to do that. Old school ways, triggered EMGs, which we did that for many, many years. Also using the pedicle finder, the ball tip feeler, post-insertion radiographs or fluoro, and then post-op CT scans. This is kind of where we've moved to the Philly Shrine, where we're able to just get an arm spin after placement, just to confirm things from the proper position in all planes. So there's some of the advantages of pedicle screws versus the old school hooks. It's definitely the strongest point of attachment. You definitely get better correction all planes because you have control of the anterior, middle, and posterior column, whereas opposed to the hooks, you just have the posterior column. If you do it right, it's neurologically safer. There's no implants in the canal. We do think you can have fewer fusion levels, although the people who go anteriorly will debate that. And definitely a reduced chance of crankshaft. Crankshaft, for those who aren't familiar with pediatrics, is once you do a fusion, if you get a fusion in the back, that curve can still grow in the front, and you can still have progression of the curve because there's anterior overgrowth. So as long as you have fixation of all three columns, the chance of you getting a progressive curve after a fusion are much lower. It does have a bit of a steep learning curve. Once you figure it out, it's pretty easy. Definitely being aware of collateral medial penetration can result in dural or neural injury. Lateral penetration, you have to be mindful of. There's definitely some vasculature out there to be aware of. And it does add operative time, which can then increase your risk for blood loss and infection. And it definitely is not cheap. So the implant density has been looked at for a while in pediatric deformity. Dave Clemens looked at it a while back and about 15 years ago and looked that he had a greater percent coronal correction with screws versus hooks. There's much better correction with bilateral segmental screws, which is what we do to try to spread and dissipate the forces across multiple anchor points. And then the more, this was thought initially that the more screws you have, the decrease your kyphosis, but now with more modern imaging techniques that we have with EOS and 3D, you can see we're actually much better at restoring kyphosis before you just were out of plane with a typical sagittal X-ray. And then, of course, Noel Larson recently finally got it published, the MIMO trial, Minimizing Implants, Maximizing Outcomes. There was a prospective randomized controlled trial of implant density in lanky 1A curves. So just these smaller thoracic-only curves looking at, they really found no difference in the percentage of curve correction for screw densities greater than 1.8 or less than 1.4. And again, a great study. Was randomized prospective. There's only one of its kind out there, but the difference in the screw densities being such a small construct going from T2 down to T12 or L1 really is only a matter of a couple screws. But did show that you can definitely get good correction with less implants and maybe save some money and time. So there really aren't any definitive recommendations regarding the number and location of necessary fixation points. General rule of thumb we have is minimum 2 levels at the top and the bottom, and then spread them across the apex to get good control for your correction. Looking at the anatomy of the thoracic spine, again, we all had this from Netters. This is what we'll be looking at intraoperatively, the spinous process going to the lamina, and the inferior facet out to the pars, and then the transverse process up to the superior facet. Lumbar spine, obviously, same thing. There's your spinous process out to your lamina, pars, superior facet, blending into your transverse process. There's your inferior facet here. So using all these anatomic landmarks will help us out for our proper screw placement with freehand technique. Stefan Perron showed this long ago. This is a normal normal spine on the left, where both pedicles are relatively similar. In a scoliotic spine, you can see the concave pedicle is elongated and narrowed, and also the dura is and the spinal cord's drifted towards that side too. So you have to be aware of that. That the concave pedicles are typically smaller and a little bit longer. So everyone's always worried about medial penetration, so they think, oh, it's going to be okay to go lateral, which it certainly is generally less of a problem. But when you have to think about it, the normal anatomy of the aorta in a normal spine is up front on the left side, but it can, in a larger curve, actually migrate posterior lateral. So again, not that you're going to have a lateral breach this much, but if you do have significant screw prominence here, you can abut the aorta, which can cause damage over time. So again, this is a common misconception. It's the transverse width of the pedicles all the way from L5 all the way up to T1. Most think that the top of a thoracic spine is the smallest, but actually L5 is quite large. They do get smaller by the time you reach T5 and T4, typically your narrowest pedicles, and they actually get larger as you go up to T1. So just being mindful of that. And then also looking at the transverse angle. So basically, in a normal straight spine, T12 is straight down. There's not much of a medial angulation that's required. And the farther you go away from that cephalad and caudad, the more you have to angle your hands. So all the way up to about 20 to 25 degrees at T2 and L4 respectively. And that's again in a normally aligned spine. So then also be aware of the significant rotation you'll have in scoliosis. So thoracic anatomy, this is one of my favorite pictures I got from Dr. Lenke. There'll be a couple of his slides coming up as he is the master at this, but then this is just what you need to go look for when you're in a thoracic spine. Again, you have the transverse process, the pars, and the superior facet. You never need to go any more medial in the medial aspect of the facet, but this is our typical starting point for our burr, where we're going to use things afterwards. So we're going to make an inferior facetectomy. We're going to cut this off with usually a ultrasonic bone scalpel or an osteotome, and that will then allow us to see this. We want to see the lateral aspect of the superior facet and the superior aspect of the transverse process. We start our burr here. We move in about a burr width, so staying just lateral to the medial half of that superior facet, and then we're going to go up or down based on where we are. And the thoracic versus the lumbar starting points. In the lumbar spine, they're virtually the same at every level. They do change, migrate a little bit in the thoracic spine. But for the lumbar spine, they're all basically at the midpoint of the TP, sort of as it slopes up, the lateral aspect of the pars, and then right at the lateral aspect of the superior facet. This is basically the starting point for for virtually all lumbar pedicle screws. Very consistent. For the thoracic spine, it's not, and that's the one challenge. It can migrate based on where you are. When we first started putting pedicle screws in freehand in the late 2000s, early 2010s, we had this in all the rooms so you could kind of reference it, which can be a lot to remember, right? And especially for those that aren't as smart as Dr. Lenke, myself included. But it basically showed where your cranial caudal starting point was and also your medial lateral starting point. The green is what we don't typically do as an anatomic approach going down. The blue is a more regular trajectory that we typically utilize. Basically, what I was taught when I was a fellow at WashU was, don't really memorize that last slide yet. Your career is not over if you can't remember this. Just an easy little jingle of T12, T12, 1, 2, 3, midpoint of the TP, and T789, top of the line. And what does that mean? So again, basing this off of where you are in the transverse process. So you start your burr here, you go in the width of the burr, just lateral to the medial half of it. And if you're at 789, you're at the top of the line, the top of the transverse process. If you're at 12, 1, 2, 3, you're at the middle point of the TP. And as you go up from 1, 2, 3 to 4 to 5 to 6, and then to 7, 8, 9, you're at the top of the line. And as you come back down, 10, 11, and then back down to 12. So I use this slide quite a bit when I was trying to get a handle for doing these, and it's been helpful for me in teaching it moving forward. So then typically, again, you have the gear shift. It is a bit curved. Your first 20 millimeters, you're going to go out laterally. So you're going to bounce off the medial cortex, which is almost always thicker than the lateral cortex. It's much harder to breach medially. Then you take your gear shift out, and then the last 10 millimeters you go in as you can medialize your tip to get a longer screw so you're not having an anterior lateral trajectory. Another way you can do this, if you're not 100% sure where you are, is the ventral lamina. This wasn't a concept I was very familiar with, but one that Larry showed me that I really like. Again, knowing that the ventral lamina, which is basically the roof and the medial wall of the pedicle. The dorsal lamina is what you see. The ventral lamina is here. You can actually bounce off this roof and then come down that medial aspect, slide down the medial aspect of the pedicle, and then you're into the vertebral body. So this is a cartoon. It's a little bit challenging to see. This is cephalad up here, caudad to the right. And this is just that sort of ventral aspect. Here's the open dura here. You can kind of slide down that ventral lamina into the pedicle and into the vertebral body. Other options you can use an awl with fluoroscopy. Again, this just sort of shows you're looking for that 3 o'clock position on the eyelet of the pedicle for your starting point. Then you come down with an awl, and you can progressively migrate it anteriorly into the vertebral body. As long as you're not crossing the medial aspect of the pedicle, when you're in about 20 millimeters, you should be fine. After 20 millimeters, you should be past the pedicle, unless you want to be past the medial border. You can also use a drill. This is becoming increasingly popular. I know Dave Skaggs is a big champion for this, looking at trying to save your shoulders. A lot of those folks who've been putting freehand screws in the wrong way for a while will have some rotator cuff problems. So he argues that a small drill is quite nice. Even in tiny pedicles, you can have a 2 millimeter sort of flexible drill. So you can see going for that similar starting point. If you have a type C pedicle where it's mostly sclerotic, having a drill can actually help wind your way down that pedicle quite easily without the sort of pushing and shoving of the awl, which can be a lot for your shoulder, but also sometimes a lot of motion for the patient. And it has been shown to decrease fluoro time and less screw revisions in a study by Seehousing back in 2015. And obviously, Terry's going to talk about this. This is navigation. I won't get into that very much, but certainly that's another option, many of which are available now. So what about accuracy? CT scans have probably the highest accuracy, as you would expect, 90 to 100%, whereas fluoro is lagging a little bit behind that at 80 to 90%. CT actually definitely diminishes with increasing distance from the reference frame. And again, we'll kind of go through this a little bit quickly because Terry's going to cover a little bit more. But the further you're away from it and the more screws you place, it actually does diminish over time. This time's getting lower and lower. This is sort of in the earlier days of navigation, where fluoro time setup was about 4 minutes for preparation and 14 minutes for CT scans. But obviously, once your team's getting good at this, this goes down dramatically. Then everyone's worried about radiation exposure. So a chest X-ray gives you about 0.1 millisieverts. Patient exposure is definitely higher with intraop CTs compared to fluoroscopies. Initially, it was about 1.5 millisieverts versus 0.3 millisieverts for navigation versus fluoroscopy. But with these new pediatric CT protocols, they've dramatically reduced the exposure for pediatrics all the way down to 0.5, so almost within a chest X-ray. And the nice thing too about the navigation, fourfold increase with CT versus fluoro, but again now reducing exposure much more, and certainly less exposure for the surgeon. I think we all also have to be mindful of the radiation we're getting subjected to on a regular basis. So what about radiation exposure reduction? Definitely using a pulsed and collimated X-ray beams reduce your radiation. Being aware that a pulse will give about 30% patient reduction and 70% surgeon reduction, and collimating it can give about 2/3 less radiation to the surgeon's hand and thyroid. And then being mindful that distance matters. Radiation intensity follows the inverse square law. So every little bit that you're away dramatically reduces your radiation exposure. And finally, how do we check our accuracy? We typically check them with a ball tip probe. Then you can use X-rays, fluoroscopy, EMGs, or intraoperative CAT scanner. In the old days, is what we did before we had an O-arm. We put our pedicle probe down there, which can give you looking for resistance. So voltage equals amps times resistance. You always want to have a higher number, which means less likelihood of a breach. But we did show that only about 20% of our medial breachers triggered less than 6 milliamps in a study we did. And then about 20% of our medial breaches triggered above 10 milliamps, which is sort of your supposed safe zone. Then you also have to be aware of what muscle groups you're testing. Sometimes it's just off the intercostals, and your accuracy is much less as opposed to doing lumbar ones. So again, sensitivity and positive predictive value are fairly low for EMGs in the thoracic spine. So we've moved to intraoperative CT scans where it can look good on an X-ray and not look very good on an axial plane. But this has been our sort of typical check now. And Steve's going to get in this as well, some salvage techniques when all isn't well and you can't find it. Obviously doing a laminectomy, palpating the medial border, or the famous in-out-in technique. If you have no pedicle or it's quite thin, you can just move your starting point out laterally to grab some of the vertebral body. And then when in doubt, you can use the other 4-letter word, which we don't like to talk about, is the hook. When in doubt, that is still okay. So, all right, we'll end that session
Hey, Josh.
there. Again, just a
Josh,
little
that
more.
was a great review of the anatomy and the different technique. So just give us an idea, what's the average size pedicle or the smallest size pedicle screw that you use?
I think for the kids, typically we'll use a 7 millimeter, maybe 6.5, depending on what system you have in the lumbar, and sixes in the thoracic spine are not typical, or 5.5s for the most part. Smaller than that, maybe 5 millimeter screws. We generally tend not to go much less than that. You can, as long as you go in with a gear shift, you can dilate the pedicles fairly well. I found sometimes we do better without navigation because we know how thin they are, but if you can just kind of use your regular techniques, you'll find it quite well. So I would say, average of 5 to 6 in the thoracic, 6 to 7 in lumbars is pretty typical for us.
And that's interesting that you say without navigation you probably do better because one of our partners, Ted Bellinger, does a lot of pediatric deformity over in Ethiopia, and basically they don't have navigation. He does it all by hand, and I'm always amazed that you guys that do it, you have the ability to make a 3D image in your mind, and you know exactly where to go. So. And although navigation is really good, I wonder if you end up depending too much on that versus your feel. So
I think it definitely has helped and hindered. I think I'm lucky, and Steve and Terry and I have grown up in the sort of freehand era, and with less of our mentors using the navigation. I know there are some folks who use navigation, and the way they teach it is they'll sort of ask their trainee or their fellow to put the pedicle probe where you think it is. Put your gear shift or your burr where you think the starting hole is, and they sort of double check it on the navigation. So that's one way to kind of teach. So if the nav breaks down, you can still operate. But again, that's why Steve and I go to Guatemala, Terry goes to Barbados. And yes, you definitely have to work with do more with less. Has always been a something we are getting used to doing. So that's been very helpful, learning how to do it by hand.
Josh,
well,
this
that's
is
great.
Jens. So I'm in the airport running to a connecting flight, but fantastic presentation. Two questions. First of all, avoiding high risk screws, like the infamous.
So cutting out a little bit there, Chapman, but I will touch base. I think high risk screws, certainly the concave apical screws are nice to have because you can grab onto them. And sorry. Yeah, so I think if you're really not sure where you are, or if you just have this really thin bite of a 5 millimeter screw that's barely grabbing the vertebral bite at the apex, we'll typically leave that out.
Vertebral screws.
But yeah, don't be afraid to leave one out. I think also sort of perseverating over a freehand screw for a long time, we've actually gotten a little bit faster if we just put a little probe in there, sorry, put a little marker in there, take an x-ray, you know exactly where you are, then you can throw the screw in. So not being afraid to bring fluoro into the room can sometimes also expedite your day. Not a sign of weakness.
Not at all, Josh. No worry.
I tell myself that. Steve does. Steve reminds me that it is, but it's good to have honest partners. All right. Sorry, Dr. Chapman. Hope that was
Thank you,
okay.
dude.
All right, Steve, Terry, you
I
want
think
to
Terry's next. Yeah. Terry on.
Okay. Let me share my screen. Can you guys see my screen?
Yep, just got to switch it to presentation mode.
Yeah. Great. So yeah, I'm going to talk briefly about navigation and robotics in pediatric spine surgery. I don't have any disclosures. So, there are thousands of pedicle screws placed every year in this country, but the vast majority of them are actually placed freehand technique. A small percentage are actually going to be placed, a smaller percentage are actually being placed using some sort of assistant device, whether that's a fluoroscopic assistant, navigation, machine vision image guidance assistance, or robotic assisted navigation. The freehand technique, as Josh just kind of went through very elegantly, has been the mainstay for the last several years. Everybody's familiar with this diagram, and it's really, really important, especially for the trainees, to at least, kind of have an idea, and you maybe use Josh's mnemonic, but really just kind of have an idea of what you're looking for and what you're trying to avoid. Even in the hands of the best of us, 10 to 15% of screws are malpositioned. That's kind of a daunting number to really think about. So that's why so much effort's been placed into new ideas and how to place screws more safely. Intraoperative navigation has a long and storied history. This device on the right may be familiar to our neurosurgical colleagues, but for us orthopedic surgeons, it looks like some sort of torture device. But they were the first attempts at stereotactic spine surgery were actually in the late 1960s by Hitchcock. He attempted to use stereotactic guidance to place screws in the upper cervical spine. The results weren't great. They were really unpredictable, and it fell by the wayside. In the early 1970s, there were the first reports of computer-assisted surgery in the British Journal of Surgery, and then the first reports of navigation and stereotactic cranial surgery soon followed. Pedicle screw placement using preoperative CT and optical 3D localizer really broke onto the scene in the mid-1990s. And in 2001, the 2D C-arm-based navigation was developed. And soon thereafter, the O-arm or intraoperative CT scanner was developed and burst onto the scene, and the modern era of intraoperative navigation soon followed. So in the adult world, navigation quickly gained traction. We followed a little bit more slowly behind in pediatrics. It's demonstrated improved accuracy to freehand techniques, and it's really standard practice in many centers around the country. These images here from Summer et al. Kind of demonstrate, an advanced suite where they're using navigation to place interbody devices in a lateral position with the laterally placed screws as well. In PEDS, the real utility in 3D imaging in the OR really kind of started with confirmation of screw placement, as Josh mentioned earlier. Bauer et al. Demonstrated a decreased rate of revision for malpositioned screws. But if you look at our pie chart here, majority of the malplaced screws anterior and superior, but these medial screws are the ones that we find really scary, as they can impinge on the spinal canal as well as the spinal cord. And also, Josh did show earlier that laterally based screws, particularly on the left side, can be dangerous in a scoliotic patient because the aorta actually migrates and can be at risk during surgery. So navigation in pediatric spine surgery has been gaining increasing popularity over the last 10 to 15 years. It has been demonstrated to be safe by multiple authors. There's been improved accuracy with similar blood loss, but with a slightly longer operative time. And there's been a decreased rate of screw malposition. This image on the right is an image from Jen Bauer's paper in Spine Deformity in 2018, which showed a laterally placed screw budding on the aorta. This was done on a CT scan obtained for a non-spine related complaint. And I'm sure that the surgeon received many frantic calls saying that you put a screw in the aorta, please come take it out. And then, these are calls that nobody wants to get. And when I ask surgeons when I was a trainee, why they'd switch to intraoperative neuromonitoring, intraoperative navigation, it's because they don't want to see pictures like this and they don't want those phone calls. Robotics in pediatric spine surgery is also gaining traction. A few centers around the country are really paving the way for it. One of the great benefits is it allows for preoperative planning for screw placement with either pre-op or intra-op CT scan. In the two series I looked at, they had unbelievable numbers for their accuracy, 98.8% to 99.6%. I mean, that's pretty phenomenal. That's out of Boston Children's and HSS, where they're doing most of the publishing. It's been demonstrated to be safe in AIS, neuromuscular scoliosis, syndromic scoliosis, and even spondylolisthesis. Josh kind of touched on this earlier. The use of intraoperative CT scanners does come at a cost. There is increased exposure of radiation to the patient. The average American does have about 3 millisieverts of radiation exposure a year, and then on average is about another 3 millisieverts exposure a year from medical imaging. The development of EOS, as you can see on the table on the bottom, has greatly decreased the amount of radiation that we expose our patients to. So just imagine we're getting multiple X-rays every year on a 12 or a 13-year-old young lady who has many years yet to live. There's such an increased risk of solid organ cancer. And then looking at this, the table on the right, we can see that there's definitely a big difference in the biplanar slot scanning imaging compared to digital scoliosis films, as well as the other studies. Dr. Larson was also part of the development of the pediatric dose or low dose setting for the O-arm. It's actually down to 0.65 millisieverts per scan, with that's equivalent to about 85 seconds of thoracic spine fluoroscopy or one PA lateral series. But it's unclear if this is actually really different to those of us who are primarily using fluoroscopy, because there's such variability in the amount of fluoroscopy that's utilized. And then there's an obvious decrease in exposure to the OR staff, which is great for us who want to avoid being exposed to unnecessary radiation. Next, I have a quick case. It was a patient of mine that I elected to use that navigation on. She is a 9+3-year-old female with arthrogryposis who has severe thoracolumbar curve. Curve measured about 130 degrees. She actually weighed about 25 or so kilograms. She had severe pelvic obliquity. On a stretch film, she stretched out to about 105 degrees. And I took a look at her MRI and measured some very small pedicles in the thoracic spine. I think those measure maybe about 4 millimeters. And you can see the proximity of the aorta on the left there. So, this is the ideal case for me to use navigation. I don't routinely use it, but in patients with very small pedicles and maybe a big deformity, I do use it. I also use it in my anchors for early onset cases. So we placed her in halogravity retraction for about 6 weeks. She stretched out to about 100 degrees, and then we performed a T3 to pelvis. It actually went pretty well. It took a little longer than I would have liked, but it was actually quite easy to utilize the O-arm. I end up getting a confirmatory spin at the end just to make sure that everything looked good. All the screws look good. Maybe one of those at the thoracolumbar junction does look like it may be a bit lateral, but overall it went very well, and it definitely saved me a little bit of anxiety during the case. So thank you very much, and open to any questions.
So you're saying navigation isn't perfect, Terry?
Navigation is not perfect. There definitely, there's a bit of a learning curve for most of us out there. I did not use it during residency or even during my first fellowship at Texas Scottish Rite. The only time I really used it was when I spent some time at the Shrine, and that was only for select cases. So I'd say we used it for congenital curves and EOS, and then in some revision cases where anatomical landmarks weren't really easily visible. I think it's really important to have it available for those types of cases. Even fluoroscopy can be a little challenging in revision cases.
Harry, would you
the
say that
question I would have, and it kind of pertains to both the first session and this, so a lot of literature on accuracy with navigation, robotics, this and that, but what about clinical accuracy? So in other words, as was alluded to before, those of us that are either older that go on mission trips get that feel for how you when you're in the pedicle, but that there's a thread or two that may be medial, but it's not doing anything. I mean, you didn't really present the literature on clinical inaccuracy when you'd have to actually change a screw because of a clinical issue, not just because your CT looked like you were a millimeter medial.
Yeah. So yeah, there have definitely been a couple studies out there which have looked at what is significant deviation. All right. So I think that less than 2 millimeters of medial breach is typically acceptable. You may want to question that if you're at the in the concavity of the tight curve where you don't have a lot of room to play, especially if the spinal cord and dura are plastered against the wall of the canal. But I mean, I think that a lot of it's clinical judgment. Again, I was fortunate to learn fully freehand, and utilizing the navigation has really just been an adjunct for some cases where I feel that it may be better, or maybe to help to kind of as a teaching adjunct as well. But you're absolutely right. I probably should have spent a little bit more time on that.
Harry, let me ask you, and as well as with Josh and Steve. So, what percent of the pediatric deformity surgeons use navigation routinely, or is
Yeah.
it just something that is used intermittently?
I think that it is changing with training patterns. We all know of, there are certain centers that probably were early adopters in utilizing navigation for every single case. So we do think that there is a certain subset or a near subset of pediatric orthopedic surgeons who have learned only on navigation and maybe not just for confirmation of your starting point. So the hope is that they would have done enough cases without navigation so that they can gain a tactile feel and understand what it feels, what it's like to actually be within the pedicle, as opposed to just solely relying on navigation and or robotics. Because we all know of catastrophic cases where there's been a frame shift in the navigation, whether or not it's kind of freehand navigation or robotic navigation, which has led to screws being placed, straight through the canal and the cord, or even being placed into other adjacent structures. So there's definitely a shift, and it's coming, and I wonder what things are going to be like in 20 years' time. Are we going to be canceling cases because the navigation or the robot's not working? I hope not. I certainly am not at that stage, and I'm about finishing up my 5th year of practice. But we've all heard of trainee surgeons or early career surgeons who don't feel comfortable without navigation.
Yeah, it's an interesting comment that, if you trained on the navigation and it goes down, as you said, do you cancel the case?
Yeah.
And maybe it's better that if they haven't had the experience. And, I would think that if they've been raised on the navigation and don't really have that much experience with freehand, then maybe you don't want them doing freehand if it breaks down. So, but that's an issue that I'm not sure how we deal with it. We started a sim lab, and maybe with simulation you can teach them how to do this, and rather than cadaver labs, which are probably the most common that we have today, but eventually have some other training techniques so they can learn that feel and get the feedback.
Yeah, hopefully some of those 3D models will get so texturally realistic that you could simulate it, but they're not quite there yet in some ways.
I mean, I remember being, taught that, if you feel like you're in the body, you're going to feel like you're in molasses or wet sand. And that was, something that's really stuck with me and I've tried to pass on. And, even when we have med students and junior residents in the operating room, we want to make sure that they get a feel for it early on so that it's familiar should they decide they want to go into spine. But, we'll see how things go over the next couple decades.
Here, can you stop sharing so I can switch over? Thanks. As much as I look at Kai.
I would say that the O-arm has offered us nice, and Terry did allude to this, instant feedback on where you are in all 3 planes, especially axially, after you put the screw in, and then you spin your screws to check. It's been great for the trainees to see where they thought they were and where they actually were. So I think that's been an added benefit of an O-arm spin, but definitely we found some screws where if we didn't have a spin, we probably wouldn't have moved them.
So to give you some perspective on, and again, this is the old days kind of stuff with fellows. So obviously with Dr. Geyer and I doing mostly degenerative. So when we first started doing pedicle screws, it was totally by feel, without C-arm, just landmarks. And we'd say, okay, fellows, like, do you feel good about your side? We feel good about our side. Let's just take an X-ray at the end and see what we need to do. That was our navigation in the old days. It's an X-ray at the end of just using landmarks. So, it's an interesting evolution.
Art's
Yeah, I
definitely
don't want to go
spine
back there
surgeon,
though.
1996.
I don't either. None of us do.
It'd be interesting to know what your threshold is to say, oh, we're good or not good. How it changes.
Yeah, and this was before neuromonitoring as well. So this was just take an X-ray and like, okay, that looks okay.
It's even more scary.
Yes, it is more scary when you think back about it.
Great. Well, thank you for having us. I think the last kind of little session will be kind of salvage techniques. we heard some of the brief overviews, and I'll go over a little bit more of the nuance, and maybe a case or two for myself and Josh. These are disclosures, nothing relevant to this talk. This is just my general approach to kind of putting screws in overall. And we heard kind of these techniques. I'll generally do this ventral lamina or funnel technique. Sometimes I'll have a lateral break. I'll feel for this lip where it steps off, and as long as it's past 20 millimeters, especially in kids without arthritic and hypertrophic joints, I know I'm past the cord, and I can medialize and get it in and out in screw. The apex, I'll do a ponte and feel for the pedicles as well, or just self it in and out in. And then, like Josh talked about, and Terry will move to fluoro and have a low threshold for that, or navigation if I'm checking my screws with a spin anyways. And then alternatively put a hook in, it could be above, put a band in the apex, or just skip it. It's a T5 on that right, typical right thoracic curve. That right T5 in the upper thoracic curve can be very small. So it's not a bad idea just to skip that one if you have to. This was Bob Gaines' been popular. He wrote an article on this looking at this funnel technique he talked about, which is basically this ventral laminar technique. You're scraping the ventral side of it, finding where the ventral TP and the ventral lamina lead into the cancellous bone. Basically, this is just the description I found online, but you kind of scrape, I'll show a picture here, you scrape a little bit, make a little hole, scrape the ventral surface, it guides you in. I've used this sometimes for a very cortical, like type 3 pedicle. It kind of guides you in the track, and I just can't advance it. I'll take that 2 millimeter drill and create a track down it, then dilate it with a gear shift, and then put a screw in. But generally for pediatrics, if you're past 2 centimeters of depth, typically you're past the cord at this point. And so if you break out lateral, but I feel a strong medial wall in the first 2 centimeters, then I'm much more comfortable medializing into the body and getting an in-out-in trajectory. And sometimes just for really tiny pedicles, it's a nice way. And then I check it with the ORM after. That's my overall approach kind of to these screws. Then you can dilate it again. Interestingly, Uncle Bob published this other slide technique, which looks the same as the actual other technique, basically the funnel technique. And so it's just an odd way to describe it, but the same thing is just feel the ventral lamina, find it in. If I just toss that out there. And the main idea of this is just have an approach to it. So whatever steps you typically do, I'll typically break down. I don't do this order. This Chinese paper published in the funnel technique, and then go costotransverse, feel a lateral border, then feel a superior. Typically, what I'll do is usually the apex tends to be the toughest one, so maybe concave left apical ones. If I'm planning on doing ponte osteotomies anyways, I'll just do my osteotomies, skip ahead, come back, and once the osteotomies are done, I can palpate the superior and the medial wall, sometimes the inferior aspect of it from the medial side, and then put my screw in. But this other Chinese paper talks about going lateral first. The downside thoracic is you got to cut the rib out, and just kind of different, just extra work that might not be necessary. But then superior, inferior, and then feel the medial side with that laminotomy or laminectomy if you need to do it. And then you just palpate it directly. And then for the in-out-in screw, like talked about, you can feel, as long as there's rib head covering it, it has this kind of granular feel. It's almost like you're poking in the disc. And then you can catch the body past 2 centimeters and medialize into it. If there's a lot of rotation, sometimes the rib may not be covering there. But typically on the left, like in this case, is a small pedicle, and we're not really going to dilate that, but you can feel that medial wall. And so with the ORM now, we can verify these after, but I'll just feel along the edge. Once I break out 2 centimeters past that, I'll medialize it. It can take a lot of force to get that medial track in, sometimes a lot more force than you might feel comfortable doing. And then once you engage it, you can feel that vertebral body in the bone. So this is an example of a 17-year-old kid, prior surgery at an outside institution. He had a prior T6 to L3 fusion. It's kind of marfanoided, but no specific diagnosis. It was labeled JIS at the time, and basically kind of wedged below, added on below and above progressed, and PJK above it. And so we took her back. And again, we don't have ORM before, but as we checked it after, I could see some of those pedicles are pretty small. So we're kind of hugging that wall on the left here, and then basically getting the body and feeling that purchase. On the left side, we had a screw as well, so it was fine. And so in her case, we did a T1 extended T1 to L4, did some pontes, palpated some of these, got those screws in. We did a PSO just to get some correction and some hooks at the top. So kind of multitude of those different techniques to do what we thought was like safe. In some cases, you may want to skip it. And I think in X-rays, you don't always appreciate what the exact anatomy is going to be like. So the CT can be useful, although there's radiation for that. Nowadays with the bone sequence or MR bone sequences, it's even better. You can probably just do this by MRI. But in this case, there's no real rib covering it. So if you're putting the screw in and out in, it probably is sitting in the breeze. There's no costotransverse junction to really cover it. And so in this case, I might skip it or put a band instead. This was a 15-year-old kid with NF1, basically tiny pedicles, and then I think we just didn't get good fixation, so we just put a couple bands across that concave apex. Usually I'll tunnel it on the convex side, so away from the cord, and then move it over and translate over and lock it in. Sometimes I've used, I think the next case is a 10-year-old untreated infantile idiopathic kid. Same thing, we had some screws, but at the apex, as we're reducing it, it's starting to pull on the screws and start pulling out a little bit. So sometimes I'll just reinforce it. You can use a band or a wire, especially if you have a ponte already. So you have the bone exposed a little bit above and below. You can just pass it and then help reinforce that screw just to give it a little more support. So those overall work pretty well. So just to kind of summarize again, my general approach, I'll kind of localize, expose, typically put a screw at the neutral level, the one I find is a little bit easiest with the most normal anatomy where I'm guessing. And then I'll start caudal and work my way up, especially with idiopathic scoliosis. There's like a general trend of rotation. So once you get one, you get a sense of how it's gradually changing. And then usually we'll do a couple in a row. If I'm working with a fellow, we'll each do a couple in a row and go back and forth. So you get an idea of the sequence. If I have some trouble, especially at the apex, I'll skip up. I'll go up a couple levels, so skip ahead, find my anatomy. And then between the two, I know their rotation will be somewhere between the top and the bottom screw. If I still have trouble with the ponte site, I'll palpate it and then verify arm. If I'm having trouble, I'll do arm spin to check my screws and at the same time just navigate. I tend to move to navigation a little more than fluoro. And then if you need to, you can always skip it again or put it back. But there's also different reasons for, like, obviously we put the screws in to get good fixation, good correction. There's multifactorial in terms of what affects our fixation. This is an example of a 4-year-old Escobar kid, basically some growing MCGR, magnetic growing rods, and started pulling out at the top. And so, not only is it fixation, but the factors that affect this are kind of bone properties, so that, patient-specific factors like that, as well as intraop variables that you decide at the time of surgery or before surgery. So what's your implant density, what type of anchors you have, the material you chose, the properties and how you bent it, the technique you used. Bracing doesn't really have a clear, at least not good evidence, but you certainly could use it to look at that. But ultimately, I view this as kind of a bone implant interface. So there's a race between your fixation, how strong it is, and your bone fusing, and potentially which one might give first. And that can be short or long depending on the factors related to it. As a brief overview in terms of fixation strength, obviously different types of fixation have different pull-out strengths. Screws tend to be our favorite one, and some biomechanical studies have suggested that screws are one of the strongest, but bands do work well, hooks a little less so. Screw properties can affect this as well. So if you have different types of screw, it can impact it. So ideally, the conical screws are a little better than cylindrical ones. Dual fine, dual course biomechanically have been suggested to be a little bit better versus single course. So again, there's all these every company has their own version of it and kind of markets their own thing. At least biomechanically, there's some differences in a lab in terms of the pull-out strength. That might buy you just a little bit of time depending on what kind of a patient you're working with and their own inherent properties. And then obviously the width of the screw. So we tend to, like Josh said earlier, we tend to put bigger screws in kids because the bone is a little more malleable, it can dilate a little bit. And so we tend to kind of get a sense of what we have and kind of feel by the tap a little bit, and then put the biggest screw we can for a good fixation. You can also supplement the screws, especially like you guys in the adult world have done a lot more, both cement and injection and these hydroxyapatite screws. We do it for the tethering a little bit. More cancellous bone, and there's some biomechanical evidence that basically the pull-out strength is stronger for these. And then there's some new stuff with this osseointegration and type of screws that's still, I think, a little questionable. There's not good clinical evidence for it anyways. In cement, and especially osteoporotic patients, has been used in adults. We haven't seen it as much in pediatrics. I think it's starting a little bit. We did a paper on OI kids, but there's always a concern that you have catastrophic failure if the bone's so weak that everything pulls out. So there's different things. I've learned this from one of my adult colleagues, Hamid Lasanzadeh. He actually will morselize bone and pack it into the pedicle. So I've tried doing this to salvage it and then put the screw in, or I've used this calcium triphosphate. There's a brand that makes it, and it basically hardens over 10 minutes. So if I have a patient with bad bone, essentially put it in. Once I have the track and then put the screw in, it seems, at least in the short term, to be very strong. It's supposed to be, it doesn't heat up and it's supposed to be resorbable, so it turns in and gets broken down over time. And then obviously other factors that, your metal choice, how stiff your rod is, all these things will impact how much force is applied to the screw and the shape of it as well, how the rod sits within the screw. So all these things are decisions that the surgeon has to make and optimize. But ultimately, it's multifactorial. You really want to try to minimize risk by identifying ahead of time. And if patients like OI patients, if you want to treat them or have them see endocrinology to help with the bone quality, then optimizing interface both around surgery and after surgery, and whatever techniques best for you work. Then I have a case as well. I think we have a case for me and a case for Terry. So this case will illustrate a little bit of some of the techniques. This was a 13-year-old kid with a tumor, neuroblastoma in her chest. Resected about 4 years ago, and to extend her spine, had T3 to 6 laminectomies. Unfortunately, over time, she had treatment, bone marrow transplant, all the cancer was stable, but she developed iatrogenic kyphosis. You can see the MRI on the left, her cord was compressed. And then about 2 years ago, started to become paraplegic, unfortunately. So she came to us in December, January, and it was a little difficult to get her to us, but we finally got her here. That's a CT of the sagittal. So there's bone in the back that had calcified and compressed it, and ventrally as well. So we put her in halo, stretched out a little bit. She actually got a little better in halo. She had a complicated course with multiple, unfortunately, issues, aspirated and needed a trach and a G-tube. But ultimately, we had an infection from that. We ultimately got her to surgery. And this was just intra-op pictures. We peeled off the bone dorsally, the scar tissue stuck to the dura. We elevated it, but it wasn't a primary dorsal compression. I think she was compressed by both sides, but really there's a ventral compression that contributed to it. We did put in an open back halo to knowing that her kyphosis could be a problem. So generally for the open halos, I'll do it for the kids that are kyphotic, or if we're going high up in the cervical spine, or they want to do a TRA decompression or something, just because the anatomy can be unfavorable. And in her case, it was tough to get some of those upper screws. So we used navigation to help with the trajectory. And we actually ended up pointing towards the end plate superiorly because the head got in the way. So even with an open back halo, we couldn't quite get the trajectory we wanted. And then placing C7, T1, T2 screws above, did a partial VCR at T3, 4, and took 4 or 5 out, and then went down to T11, 12 with her screws distally. And so in her case, it wasn't necessarily the anatomy that was a little tough. The pedicles were not large, but really the kyphosis made it difficult to get the trajectory we wanted to. And fluoro might have been difficult in this case. I found fluoro in the really kyphotic cases can be, you just won't bend, it won't tilt forward enough that you can get a true kind of AP view of the pedicles. So navigation helped in this case, it really worked. Even with the open back, our instruments hit the halo frame, so it was really tough. So flexing her more in halo might have helped. Sometimes we've done is taking the handles off so the handle doesn't bump the frame, so you get a better trajectory just with the shaft. And then in this case, we actually had distal fixation, so we could get a couple of screws distal, and we actually used that to pull her up for the set screws to lock to the right angle to lock it in place. So we kind of elevated her once we had a little bit something distal fixation, just to get that trajectory. So you almost lift her up the bed a little bit as you aim your trajectory a little better. And so that was her post. We just an ultrasound to make sure the cord is decompressed. And then overall, she's doing better. So that was the intra-op just a couple of weeks ago, but these are just some videos of her starting to move her legs. So far, promising results. We'll see how she does. But it's not always just difficult to get the screw, but sometimes the angles can be tough, and all these tricks can help you with those screws and get the trajectory you need. And that. Any questions?
This is really tough
amazing
stuff. Yeah, it's really tough stuff. I mean, as Dr. Gar said, we don't obviously see a lot of pediatrics, and I go back to when I was a resident, and who said they were at Scottish Rite? Terrence?
Very.
Okay.
Yeah,
Yeah,
Terry was.
I was a UT Southwestern resident, so I remember the Scottish Rite days, and we used to see stuff that just you would never see anywhere else. And it's not something you see kind of in the private world, around Dallas. And so, I mean, it's amazing what's come about. I mean, obviously, expandable growing rods and things like that, and some tough stuff, the congenitals, the neuromusculars, and like I said, we don't have a ton to add, but just we're really impressed with the work that you guys are doing.
Thank you. We
And
appreciate
And it also brings up the point why this kind of surgery really needs to be done by people that just specialize in pediatric deformity. Because there's some folks that I see out in our community that will do a little bit of pediatrics, but I don't think that you should do a little bit of pediatrics. I think you should do it all. And you showed some very, very tough cases, all of you did. And I just think that it should be done at centers like Shriners and other pediatric centers.
Yeah, so it's interesting, I don't know about it was in Philly, but in Dallas, spine is everywhere except pediatrics. Pediatrics is pretty much confined, like 90% to Scottish Rite, whereas, complex spine of an adult nature is really done everywhere. In fact, it's more not done at the medical school than at the school, whereas, obviously pediatrics is pretty confined. Like Rick said, it needs to be done in a place that does that kind of stuff all the time.
And it's interesting. So we have Ted Bellinger that goes to Ethiopia, and Izzy Lieberman goes to Uganda, and there they see all these, amazing deformities. In fact, the fellow was just showing me this one that had, I think it's a 150-degree kyphosis that they did multiple osteotomies, and it's nice for the experience. And granted, they're working under, pretty sparse conditions, unlike what we have here with all the different fancy technologies. But it's still the kind of thing that, they may get exposed to it, but they can't really do it on a regular basis unless you're working at a pediatric center.
So the big, 40,000 square foot question that I would ask is, we do these conferences every 2 weeks or whatever, and a lot of, whether it's pediatrics or adult deformity, et cetera, there's a lot of discussion on navigation and robotics. And the conclusion of every single seminar that we do is, this is totally the future. It is on the way. Do you see, obviously you're younger in your career, 10 to 20 years down the road, not necessarily a name brand technology, but a certain type of technology that you see maybe, what ends up being kind of the standard of care. Kind of like, I don't know that I would get in a self-driving Tesla cab in LA right now, but I know people that have. But ultimately, I think we're all going to be going in self-driving Ubers or whatever. Where do you see, at least, from a technology standpoint, robotics and navigation being in the middle to end of you guys' careers?
I think
Yeah, I mean,
it'll
I
take
think,
over.
once you guys go ahead.
Yeah, I think it'll take over. I think once the technology and like technology is advancing so quickly, I think it's like already fourth generation robotics out there. Like it just improves every generation. I think for me, it's not quite there yet in terms of safety and replacing, technical ability and experience, but I think it will. And I think it right now, it probably in my mind, it kind of evens out maybe the low and the high performers. Like the low performance probably brings up, makes it safer. So the bar is a little bit high, the safety bar is a little bit higher. But I think eventually it'll be the standard of care across the board.
Yeah, Scott's heard me say this again. I mean, I'm a big believer in technology, but you see the learning curve and you see it goes step by step. And we look back on a lot of things that we do today, how we started out. And the pedicle screws, at least for the adult deformity, where the pedicles are a lot bigger, and granted, not like the pediatrics. But I do believe that you know, in a slow progression, will it be 20 years? Will it be 30 years? I mean, who knows? But I think eventually it'll get there. And just like, you know, the haptics, they have haptics that, you know, you can use with robotics and with the Da Vinci and things like that. We haven't really explored it much in spine, but I think that eventually it'll get to the point where, you know, you'll manipulate your pedicle screw, Steve, and you'll say, hey, you know, this doesn't feel right. And it'll give you that feedback. And as hard as it is to imagine today, I really believe that we'll get there. But you know, who knows when? But eventually it will. And but you know, the work that you guys do, I mean, I take my hats off to you because taking care of these, you know, all these horrible pediatric deformities, which I don't know how many we see, how many you see today, but there's obviously still enough that are around. I mean, at least the idiopathic, I don't think we let it get as bad as what you see. And, you know, certainly what our partners see in Uganda and Ethiopia are just terrible.
I think, you know, Steve and I and Terry a little bit too did 50/50 adults for a while. And, you know, that the adult degen and, you know, the revision cases on there, I think were nothing to shake a stick at either. So I myself ran away from that. And that's what made my blood pressure go up and the peds has made it go down. So, you know, we've all sort of found our place, but definitely agree that robotics is the way of the future. And if we think we're better than that technology, you know, in perpetuity, I think we're kidding ourselves. So definitely it's coming, you know, but it probably at least 10
And
years away.
And Josh, look what you guys are doing with pedicle screws. Remember the thought of pedicle screws? You know, putting them into the pediatric spine with the little pedicles, and look how damn good you are now at it. And so again, that's just part of the progression of the, you know, advancement.
I tell everybody, so I was one of the last surgical patients of Art Steffi back in the day in '96 when I had a pediculectomy, and I was very close to needing pedicle screws and a Steffi plate. And you know, at the time, this was some revolutionary thing. Now I look back on it, thank God I made it out without it. So yeah, things have changed over the last 30 years.
Yeah, and it's incredible what you do now. And you know, as I said, I take my hats off.
Well, thank you
So
very much
any
for
other
having me.
questions? There were a couple comments from I think in the chat room. I think Terry or Steve answered them.
Yeah, I think we kept up. I think the most important Philadelphia issue of the week is that the NFL voted not to outlaw the tush push. I was like,
We got another
okay,
year.
yeah, another year of Philly's dominance over the Eastern Conference. It's like it's rough for us in Dallas to see that, but you know,
Well, listen, we have a general manager that doesn't want to give up.
We're hanging on to his
Well,
loyalty.
listen,
yeah.
this
You,
guy, Scott.
no, I was just going to say this was a great session. I learned a lot, just obviously not doing peds for like 40 years. So thank you guys. I thought this was a really good session. This would be great for, you know, trainees and such to pull up, you know, on YouTube since Seattle Science reposts these things. So really appreciate it. Look forward to your next one.
Yeah, this was
Thank you.
great, guys. I appreciate you taking the time, and it was great. So
Thanks
have a
so
good
much for having
evening,
us.
and
Yeah.
we'll see you next time.
Pleasure. Take care,
Definitely.
Don.
Thank you again.
Thank you so much.
All right.
Good night.
Bye-bye.
All right, take care.